non-nutritive sweeteners, and special labeled food for diabetics. The effect of alcohol and blood sugars. We'll see the principles of meal planning, health education tools. We'll do some little bit of calculations, and then we'll conclude. So basically, as an introduction, the most important thing we need to understand by this session is that nutrition management in all is the cornerstone of diabetes care. That is both in type 1 and also in type 2. But today we are talking about type 1. So we recommend that nutrition therapy for all children, adolescents, and young adults with diabetes type 1. And this nutrition counseling or advice should be adopted culturally. You don't just say, find the history, the family tradition, which will be of help finding out about the cognitive, psychosocial circumstances of this child and family. We all know that in our country, Kenya, we have around 43 tribes, and our culture and our dietary habits tend to be different. So as a diabetes team, it is very, very important to have this in mind. And finally, we need to understand that food security, as we talk about type 1 diabetes, are they on insulin? Are they food insecure? Or are they having abundance of food on their table? And that will be done through the assessment. So our nutrition management therapy goals, number one, why we need to do this age group. Number one, we want to provide calories. Remember, they are growing. We want to ensure that they're getting enough nutrients to achieve their body weight. Remember, these type 1s, depending at what diagnosis they are, one thing, they are growing. So we want to achieve the optimum weight, like the rest of children who are not diabetic. We want to obtain normal growth and development. Also avoid restrictive diets. Like we have come from now where we are, where children type 1 used to be very, we used to restrict a lot in their diets. Don't eat this. This is the amount. You decide to give them like 1,000 kilocalories from nowhere. So what we want to avoid by the end of this, we want to achieve a proper weight. We want to ensure that they are growing well. Like the only difference they have diabetes, which require a team of multidisciplinary management. These are the people, the children we want to have good health and to have healthy food choices, depending at what age. When we promote good health choices, remember type 1, they remain type 1 as adults and even to elderly. So if we start ensuring that they are having healthy food choices from the beginning, then they'll grow up being healthy people. Another thing, what we want to do is to maintain good glycemic control, almost near to normal. And that is why you get that most parents, when they see normal sugars, almost a month, my child has very good sugars, they even go back and doubt, is it okay is it true that my child has diabetes? They start again reflecting back. So our main thing here is to have good glycemic control, almost to normal sugars as possible. Remember, they are young. If there is poor glycemic control, sugars are not well taken care of, later on when they grow up, they might end up having elevated cholesterol or elevated lipids. So those are the things we try to achieve so that their blood pressure, the lipids are within the normal range, which is recommended. Then we want to delay or prevent the complications of diabetes, both acute and long-term. In terms of acutes, there's low blood sugars, high sugars, which will be talked about maybe as time goes by. And this is basically a threat to the family, more especially low blood sugars. Long-term complications, which comes along because of poorly controlled diabetes. Those are the things we want to delay, or we don't want to see them completely. Then we want to maintain a healthy eating, food choices, which are scientifically evidenced. When you limit, you need to give evidence. You don't just say, don't eat this, don't eat this. Remember, these children, they interact with the non-diabetics. So we should use good terms when we are saying we need to limit this. Now, as a nutritionist, remember, a nutritionist is part of the team, the diabetes care team. So the most important thing, what we need to remember, as a diabetic team, as the doctor team or the nurses team, us as nutritionists, we also have a process we call nutrition care process. For the nutritionists who are here they understand a lot. The first thing, when you send this child to me, when you send this child to the nutritionist, we are known of, we check the weight. The first thing, we do the nutrition assessment. You get this child coming, newly diagnosed, has seen the doctor, maybe medication has been prescribed. So the second thing, go to the dietitian, go to the nutritionist for counseling. So what am I supposed to do? The first thing, I'm supposed to do nutrition assessment. This, I have to find out so many things. I have to find out if there is, like we say, we have to find out the weight. That is the anthropometric assessment. We have to do dietary assessment. We have to assess clinical assessment. If there's any deficiency of vitamins, the symptoms can be manifested physically through maybe the eye, like there's deficiency of scurvy, you just assess. Then there is a biochemical test. You can check the HbA1c, you can see the sugars. If there's any other labs that you can help you during the assessment. Then there is also an environmental assessment. This child, remember maybe it depends where you are, which county you are. It's good to do the environmental assessment. See if this tells you about food production, it tells you about sanitation, water, it tells you about the household size in this family, so that as you plan, you know very well in this plan I'm doing for this child, there may be around this number, and are they food insecure? So those should come in your mind. Then actually you need to do the physical assessment, that is exercise. Is this child active? And is it that you are going to tell this child not to be active because he's diabetic? So those are the assessment. That is what we do in nutrition care process. After that, you do a diagnosis. This diagnosis is going now to help you to do a nutrition intervention. What am I going to do? I'm going to do nutrition counseling as an intervention. I'm going to do an individual diet plan as an intervention. Then this is what you need to monitor. You have done your plan, the sugars were very high as the diagnosis. You do a plan, then now you monitor this. So newly diagnosed, you can see them frequently as a dietitian, as a nutritionist. Then you continue now, maybe seeing them in 3 months, then eventually twice 3 months a year, depending on how the sugars are. But still, every time they come to the clinic, if there's any question that the children or maybe the family needs to ask, that is why we encourage nutrition, we encourage multidisciplinary and a comprehensive clinic where there's a dietitian, there's a psychologist, there's a doctor, nurse, a social worker to help out this family. Now, before we move and see what we need to do with these children, There's some what we need to tell them. Like the diagnosis of diabetes can start from infancy. It can start from infancy. Then if we come to this 2 years old, 3 years old, those are the infancy daughter preschoolers. Dependency is on the parents and the caregivers. They have what we need to understand about them. Their appetite is just variables. So routine, small, frequent meals, routine meals can promote improvement in glycemic outcome and nutrition adequacy. Because of fear, you get most parents will end up or will start maybe giving them, that is what we call grazing on small food quantities, should be discouraged because this can lead to maybe a child, if it's mealtime, will refuse to eat. And this can also interfere to glycemic control. So at least counseling should be done that once these small meals are done through the day, because if it's a daughter of 2 years, you can imagine the fear in these parents. They'll say, maybe my child will have low blood sugar. That's why I'm feeding after 1 hour. It's like what this child ate, it's not enough. They should be encouraged that if a child eats at 8, should wait some hours before having the next meal so that to have good glycemic control. The small quantity which are given annually, hyperglycemic would continue through the day. So our aim here is to have optimal nutrition, which will give sufficient energy and nutrients. Because this group, they're really growing up. So optimal nutrition is required for sufficient energy and nutrients. So that's why assessment is very crucial so that the parents, caregivers can be able to know how to go about. Then continue with this group. That's where I've already said positive parental role models. We should encourage parents to start earlier to promote and improve cooperation in terms of health choices in foods, like encouraging them. If it's a 3-year-old, you can even, in health food choices, you can give some rewards, not giving sweets. You can give you can clap for them for eating healthy foods. Parental anxiety is very common in this age group, but more especially, they don't understand if they can give insulin, then start eating. If a child has a poor appetite, I don't know if he's going to finish this meal, so they are left in dilemma. That's why a lot of anxiety comes. So if they have passed through the doctor, I think the doctor will encourage them when to give the insulin with this group of children, more especially if the child has a poor appetite. You have just put insulin, and maybe this child is using short-acting insulin or maybe daily multiple insulin in a day. The parents can be very anxious because of low blood sugars. So the caregivers who are left with these children should also be taught about diabetes management. What about the preschoolers? These are children now going to school. As you can see in that picture, maybe there are more 2-3 diabetics in this picture. Just avoid Nairobi. These are maybe somewhere in interior rural areas. It doesn't mean it's in Nairobi where we have type 1 diabetes. They are all over Kenya. So teamwork is the main issue here in terms of families, the medical staff, school nurses, diabetes team should come in handy to manage these children at school. So this is the time if they're eating at school, lunch, they get at school, at least parents are supposed to know how this child is going to eat. Once the parents have communicated to the teachers, if the teachers can cooperate very well, the teachers to cooperate about snacks in between, the child will continue a normal life, ensuring that he is not missing classes. The parents don't need to come to the school so that they can be able to ensure they supervise lunch, they supervise. But as time goes by, the younger one, they need that supervision. Until now, they are able to be left to do how they go to school and come back on their own without parents needing to go to school. So that's why multidisciplinary is very key here, okay? Because you will not have your own school as parents. It's just to mingle around with other children. So we still encourage individual advice in this group regarding the carbohydrates intake in terms of preventing hypoglycemia. In the events of sports, like they can have meals before going for break time when they are very active, and when they go for sports day, when they come, you know, they should mingle around like any other children. It's not that you are limiting them. And this is what most parents will do. They start limiting them. And when they grow up, that's why they repair at adolescent stage, when they're adults now. Because I've been limited and my friends are doing this and I'm not able to do it. So still we encourage healthy food choices, food portion size. We encourage physical activities. And also if there's any weight gain, we should find out as a team who are working out on these children. And these are children who will decide, Leo, I'll go to sleep at my grandpa. Are you, or maybe my friend has a birthday. Are you going to stop them? Just encourage them, discuss together and agree. If you are going to enjoy this piece of cake, this is how you are going to do it. So they should live a flexible life. It's not a restrictive life. As they grow up, that's why most of the children, type 1, at the adolescent stage, if you know, they just repel. Then continuous education should continue. They need supervision and support before we say that now they're able to do it. And we'll talk about carbohydrates counting later on, although it's not a major topic today. We are just talking basically about nutrition in this type 1 diabetes. We'll recommend weight monitoring to continue. As a nutritionist, when you do a weight, you plot it on the graph, so you see next visit how the child is doing. Now, this is another critical stage, adolescents. They want to be independent in their food choices and have more freedom on what to eat, how much, and at what time. So that is why from the beginning, depending at what age they got diabetes, we normally say below 18, 75% of type 1 diabetes diagnosis, normally it is below 18 and the peak is around 6 to 11. So we say this is the time they have friends and their main concern is about their shape. It's about how I look, identity crisis. Remember, there are children like any other. If you have an adolescent in the house, so who is not diabetic, the same way a type 1 diabetic during an adolescent stage behave. So with this freedom they want to have from above, it can negatively affect their glycemic management and food choices. My friend is eating this is what I want also. That is why the education is very crucial about healthy eating, nutrition, and self-care management. If they were diagnosed at a very early stage, maybe 6 years, so the education is very important. Psychological support, very important at this age, because if not done, it can lead to depression, and in turn can lead to poor metabolic control. The challenges, the behaviors of eating we normally find here, they want to stay out late. They sleep in. I want to sleep somewhere. I want to go to my auntie. I want to go to my friend. They want to skip insulin, most of them. Although those who have been taught slowly and managed well, they'll still remember to have their insulin. Missing meals, eating disorders, which are very common in this group, and more especially some cultures, you'll find them at this age. Some, they even start drinking. We said we keep on educating, monitoring their sugars because they are concerned. Maybe it's about their shape. Are they losing weight or are they gaining weight? If they're losing weight, maybe it could be they have very poor glycemic control. If it's weight gain, maybe dosages of insulin needs to be adjusted, or another meal plan also needs to be adjusted to meet teamwork. Parties, vacations, and peer pressure, it's the talk of the day in this group. So this is the group now you decide to discuss. You know, maybe when they were young, you were ordering them, okay? As parents, you start ordering them, but here you sit down and discuss, you solve problems, and you set targets. And in this stage, we have in our country, Kenya now, it's like every household is going to go to technology way. And you see them Googling and saying, I've seen this app about carbohydrates counting. I've seen this app. What am I supposed to do? If you have not taught them about the effect of carbohydrates counting and the sugars, themselves they'll come and say, I've seen this app and I didn't want to use it. So exercise routine, understanding the impact of foods in glucose levels, and encouraging them to have food diaries, what they have done. So this is a very, a group which will go to adults with either sugars well controlled or poorly controlled, depending on how we manage them at this. Remember again, at this period, the growth spurt also comes in like infants. They're growing up. Their muscles are going up. Their height is really going up, more especially boys. All what is happening in this group, they need to be supported nutritionally, health choices, so that they can grow well and having good health choices of foods as they grow to adulthood. These are the disorders which are very common, and it is very common in type 1 diabetes female adolescents. Their main focus is, I don't want to be fat. When I look my shape in my mirror, I look bad. It's crisis identity. They eat and vomit. They restrict carbohydrates intake. They don't want to be fat. So with the way I said, with psychological support, these things can be overcome. So our first poll question. Nelson, you can. Yes. So please, optimal nutrition is required to provide sufficient energy and nutrients to meet the rapid changing needs of children at different stages of life. Now, is it true or false? We can see from the listeners, if you've been listening. You have 30 seconds to answer. Are we through? Nelson, you can give the results so that we continue. Wow, this is very encouraging. It means listeners, participants, you are listening. Optimal nutrition is required to provide sufficient energy and nutrients to meet the rapid changing needs of these children. Remember, from infancy, the requirement is high, and during adolescence also the requirement is high. So 98% said true, which is correct, and 2% said no. So the answer is true. So we continue. So sorry for that each. That is technology. As my slides refuse to move on. So we'll talk about carbohydrates. We'll talk about proteins. We'll talk about fats and other micronutrients, which are very crucial for a child and even for adults. So carbohydrate requirement in children and adolescents are individually determined by the age, gender, and the activities this child that are doing. So some clinical evidence suggests that individuals can consume 40 to 50% of carbohydrates, which can help them to achieve the postprandial glycemic targets. That is by ICEPAD. I love using the website of ICEPAD because they really help us on management of children with diabetes. So health sources of carbohydrates foods should be given a priority. So as we talk about health choices, we need to tell them about what are these carbohydrates, how do they affect the blood sugars, and what are the health choices of these carbohydrates. So a method of quantifying the amount of carbohydrates is also needed, which we are going to see later on as we move on in our slides. The sources of carbohydrates, as you can see, I tried to go tradition in what we do on the ground. You can see matoke, you can see the Irish potatoes, sweet potatoes, ugali, bread, the most common sources of carbohydrates, we call them starch. So they need to understand what are these sources that I need and what are these healthier choices, which are very crucial from where I come from, depending where I am. Why are they not moving? The next macronutrients we want to talk about is protein. We know very well during infancy, protein requirement is very high. It keeps on reducing to childhood, to adolescence, and by lifespan, that is the requirement. From 10 years old, 0.8 to 0.9 kg per day in later adolescence. That's by lifespan. So about proteins, they vary, and also it depends on what you put on the table, your socioeconomic status, and availability. So that's why we have varieties of proteins that you can advise the caregivers, the caretakers, the parents to have for the family. So these proteins promotes growth when sufficient total energy is available. It builds and maintains muscles, tissue, skin, hair, and skin. So it doesn't raise the blood sugar levels. So the sources of proteins include meat, fish, chicken, poultry, nuts, legumes, cheese, milk. So it's about what is available. And basically, you'll get that like in this economy, which is going up, few months ago, beans were very expensive. The legumes were very expensive. Families were not able to afford. Families were eating white rice without beans. So it's about, depends on the socioeconomic and availability of that protein in the family. If they can afford meat, that is fine. If they can afford any varieties of beans which are indicated in this, that is fine. If it's small fish, we call omena, good to go. Some fats. So the nutritional guideline about the lifespan recommends 30 to 35 total daily energy intake to come from that. That is when you have done the assessment, you know the calories this child is going to have, either if it's 1,500. So 30 to 35 should come from the total daily energy intake. We are told we should limit saturated fats. It should be around below 10%. And we should encourage unsaturated fats as it reduces cardiovascular risks later in life. So if we continue giving them saturated fats a lot, we are putting them at risk of developing cardiovascular diseases later in life. When we talk about monosaturated fats, these are avocado. We thank God in our country, at every household in our country, they have a tree, avocado, I can say most of the families. Nuts, we have peanut butter, not even to mention all because it's expensive. Vegetable oil like corn, soy, and sunflower oils. So those are the oils that we encourage to be used, but in moderation, and reducing saturated fats and encouraging more of unsaturated fats. So 10% of our saturated fats should come from our energy. And when we talk about saturated fats, these are full fat dairy products, fatty meats, and high fat snacks. Then there's this kind of oil, which now, if you go to every supermarket, that is the first thing you encounter on the way before even you go to pick what you want to pick from the far end. The cookies, the cakes, the deep fried food, the margarine, they tend to have a lot of trans fatty acids. And when we talk about trans fatty acids, these are vegetable oils, which are processed and solidified in the process we call hydrogenation. So the recommendation is we limit them as much as possible. We limit them as much as possible. Like in the country of South Africa, they have decided you have to say how much of the trans fatty acids that are in your food. They just want to do away with this. So I wish our country will also do that. So the second poll question, Nelson. Nelson. Okay, the question asks, which of the following statement is true? 30% of the calories consumed daily should come from fat sources. 30% of calories consumed daily should be from protein sources. 30% of calories consumed daily should be from carbohydrate sources. None of the above. So which one of the statement is true? 30 seconds. Are we through? Yes. Now, Nelson, you can show us the results. Which one of the following statement is true? 30% of the calories consumed daily should come from fats. 30% of the calories consumed daily should come from carbohydrates. 30% of the calories consumed daily should come from protein. None of the above. I can see 26%, which is the correct answer. 30% of the calories consumed should come from fats. 30% of the calories consumed should come from protein. Number one, that is 30% of calories consumed should come from fats. That's the correct answer. Remember, we said carbohydrates range between 40 to 50% of our daily energy intake. 30% to 35% should come from protein. Then we haven't gone for protein. We said about the increase from infancy and the reduction in childhood and also during adolescence. It's about, we calculated about, we can say 15 to 20% should come from the energy intake, daily energy intake. Now, let us check what those 3 micronutrients that we have talked about, how they affect the blood sugars. So when we eat carbohydrates, when we eat proteins, and when we eat fats, what I'm seeing down here, the way fats are digested, they take time. They don't pick up. It's something which goes, you see, it's just a mimic, like it acts like almost like the way the long-acting insulin does, but this is food, fats. And you see the way proteins, it takes like 3 hours to pick, and then it will start coming down. So it takes like 4 hours. See, carbohydrates, food. Within 2 hours, sugars are at the peak. And within that, it comes down and drops. So we encourage mixed food. Don't just give rice. Try to look for beans, try to look for green grams and some vegetables with that food cooked with some little oil. Then you get that you are able to have good sugars. Remember, diabetes management, the cornerstone. So we should start encouraging mixed feeding, that anytime you are feeding your child, we encourage them that they should have a balanced diet. They should have carbohydrates, food, proteins, fats, so that to have good glycemic control. Because if it's only carbohydrates in the meal, it will go up within some short time, then the sugars are dropping down. But when it's mixed, proteins, fats, and the carbohydrates, you get that the way the body will release sugars to the blood will be very slow. So let's talk about fiber. That's one of the best thing. Like we say, fiber, we get it from vegetables. Basically, encourage children to eat vegetables with diabetes as much as possible. And we should be role models. Like caretakers should be told, parents should be told to be role models. They should give them vegetables to participate in cooking. When they cook and when they participate, they'll be able to eat, because it will provide for them a lot of the vitamins and it will give them fiber. This is undigestible stuff, and they will not have any effect on the sugars. So the insoluble and soluble fiber, and the best source of fiber, we encourage that eating whole grain, vegetables, fruits, beans, will be able to have. Having this, ask them to increase fiber in the diet very slowly, because it's not that a day you want to achieve 19 grams of fiber. Slowly, so that the body, the stomach, can be able to accommodate. Otherwise, if you just tell the child to eat a full 1 cup of vegetables at a go, you are doing more harm to this child. You'll make harm by this child hating to have vegetables, because it will affect the tummy of this child. What about micronutrients? Vitamins and minerals. We normally find them in our food. And when we eat raw vegetables, like we say raw, and in this era, eating raw vegetables, we are not safe because of the chemicals which are sprayed on food. But with proper preparations and washing and processing it well, because when we talk about vitamins and minerals, our storage, processing, and cooking, it leads to process. But children of diabetics who have diabetes, the same vitamins and minerals requirements, the same they require like the healthier children. So there's no need for supplementing unless there's a deficiency. And this can be done maybe if a biochemical test has been done, is when you will supplement. Otherwise, we don't supplement and there's no need. That is why we say when you plan the meals well, you are able to meet all these micronutrients allowances. Sodium, encourage these children as younger, tender age, as caretakers, as caregivers. They should ensure that we limit the sodium. We teach them to limit sodium intake at this age, slowly, not even at this age. Everybody, we should limit the amount of sodium that we need to have. Like the guideline of ISPAT says, children 1 to 3 years, it should be 100 milligrams per day. That is around 2.5. When you are making food and are eating, avoiding salt shakers on the table. 4 to 8, it should be around 1.2, that is 3 grams. 9 years and older, around 15 milligrams per day of sodium. Because too much of sodium intake when they're younger, as they grow up, it puts them at risk of developing vascular diseases as time goes on. blood pressure coming in. So those are the things that we'll limit by teaching them on how to use salt on the table. What about hydration? It's not a nutrient. It's not going to give us anything, but children are more riskier of dehydration than adults because of the body weight. So 70% of our body is water. So the key thing is that we need hydration. Because these children end up losing a lot of water. Remember, they are very active in school and wherever they are. So we need to replace, we need to encourage them. This is the issue of water and children. They don't. But if they are encouraged, they can be able to have water as time goes by. How do you tell if the child is dehydrated? Just check the urine. If it's pale yellow, then the child is well hydrated. If it's dark, then it's a warning that the child needs to be hydrated. So we have there's some research has said that when a child is dehydrated, like 1% of the body weight loss, this child cannot be able to concentrate even in class. The cognitive function of this child is reduced. So let us encourage our children, not necessarily those who have diabetes, everybody, even us as adults, we should have enough water. We should have enough water as time goes during the day. There are so many, when you have thought about health choices, because of technology, those ones who are not able to have, like they cannot have something without sugar, because the function of the sugar is to ensure that that sweetness is there, that property of food is there. So that's why we are seeing a lot of diabetic products in the market. Remember this child who is 6 years, newly diagnosed diabetes, and you are introducing these diabetic products that now this is what my child is going to eat. Those things are not nice. So we say they are very high in fat, so we should stop recommending them. They are very expensive for nothing. Diabetic charm, what? They contain a lot of sugar, alcohol. Then they act like laxatives, and they'll end up upsetting the child's tummy, leading to diarrhea. So, like if you want to treat the child, we say, it's my birthday, or maybe I've seen, these are children still. They are not different like the non-diabetics. They mingle around. They can test something small from a normal sucrose occasionally, but it should be counted as carbohydrates. So the non-nutritive sweeteners, there are those which Food, Drugs and Administration have accepted, but acceptable daily intake in amounts. If you go to the website about non-nutritive sweeteners, there are those sweeteners which they have been accepted, but what we need to do, if they accept, you don't force them. If they accept not to use it, the better, okay? The better not to use it. If they go on, like in European countries, that is what they use, But in our country still, we just go without, which is the best, okay? But if in case you want to use the sweeteners, there are some limits. We don't just use like any other. It's like it is being controlled by the Food, Drug and Administration. So the instructions which are there is what you need to follow. And the instructions are given about according to the care of the child or maybe the adults. So this is the group again, will not miss to just say they will not have alcohol, but also there are some cultures we say, like in our country, Kenya, we try, but this age you find them, some have started having alcohol. So it's not something that you need to hide. Talk to them, be open, because some society less strict like our country, but still alcohol is abused. So it contributes to so many healthier risks, like if they have it on empty stomach, it can lead to hypoglycemia, moderate, which can be very severe, because too much will suppress the glyconeogenesis process. So very bad low blood sugars can occur. It impairs growth. Remember, here they are growing also, but when they take alcohol, depending on the amounts they are having, it can lead to hormonal impaired growth hormone response. Then it can lead to hyperglycemia. Some alcohol have some sugars, carbohydrates. So, and it can lead to so many harms, like to this type 1 diabetics. So we should encourage them if they can stop. For those who have stopped, that's why we need to be friends. And that's why when I listened to our last presenter, we need to have an adolescent clinics where they come, they encourage one another so that they get this support. No, so that they can be able to move on with their diabetes well. Then when they're just moving around, they just come to the clinic, they find their adults, their young children, younger than them. So they repair. So having talked about that, now our main thing as nutritionists, remember we said the nutrition care process is individual assessment, then you diagnose, then you do an intervention which should be individual, then this intervention is what you're going to monitor. So in meal planning, what you are trying to do, it's a guide you are giving the family on what to eat, how much, so that to meet the nutrition requirement, and at the same time to keep the blood sugars to the level which is within the target. And in a meal plan, we say you have to consider some goals of this family, the tests of this child, the lifestyle, any medication you need to find out. And also, as a nutritionist, when you are doing meal planning, this is from the clinical dietetics manual, we have the 6 principles that you need to consider as a nutritionist. What are you supposed to consider? Adequacy in your meal plan, in all nutrients that we have mentioned. The food should be balanced, and nutrients in the diet. Balanced meaning to avoid having one food group on the higher side, the other on the lower side. Nutrients dense, meaning some foods can provide some nutrients which are dense, like if I eat nuts, I get more nutrients from that nuts. It should be in moderation in diets, meaning moderation over consumption and also over under consuming. Because remember, if they are losing weight, if they are adding weight, why are they adding weight? Is it that they are over consuming or they are under consuming? Varieties, what is in spinach is not in carrots, what is in rice is not in ugali. So we encourage when you are doing a meal plan or when you are doing an individual diet plan, it should be based on the principles of meal planning. Very crucial: adequacy, balanced, nutrients dense, energy dense, moderation in diet, and variety. So what are we going to do? What tools are we going to use the most common tool that we have in the office, which we will pick very fast to show on how you are going to eat at home, is basically a healthier bread model. It's a tool which is very fast. Even doctors will just say, draw a plate and say, this is how you are going to do your meals at home. But I can say that is very quick if the nutritionist is not around, because in this individual meal plan, it's a meal plan which is written. Patient X, this is the amount of calories that you are going to consume, 1,500. How are we going to achieve this 1,500? Morning, you should be having this amount. Lunchtime, you should have this amount. And in the evening, not about guesswork. Remember, carbohydrates providing 40 to 50% of the 1,500. Then fats will contain 30 to 35 of the 1,500. So in this case, depending where you got this child, if it's 10 years, if it's 6 years, this is a child you are going to work with, because you are going to change this plan, okay? As the child grows, the requirement changes every year. Remember, the height is going up. Either maybe the child is not adding weight. So that's why individual meal plan is recommended. So another tool that I use very common is it's good to teach them. Like these adolescents, they'll come to me, this is what I found. If I eat this meal, this is the amount of carbohydrate. You know, they are very ahead of us. Even a 2-year-old, grade 2, can come with a app and tell you, this is what is happening. You know, they are now exposed to technology. Don't hide anything. That's why we should be ahead of them, knowing this technology about diabetes. Now the world has come very small. What is done in European countries, these children are able to access. So don't restrict them. If they're able to count carbohydrates and how they affect their blood sugars, be flexible as a doctor, as a nutritionist, sit together and learn how to do it. So like carbohydrates counting, it's just another meal planning tool. It's not a diet. It's to understand how food choices affect blood sugars. When I say my child is on 1,500 kilocalories in 24 hours, and I distribute my meals, depending if I'm using NPH, regular insulin in the morning, lunchtime, and in the evening, I'll just say I'm doing basics, okay? In carbohydrates counting, I'm just saying this amount of carbohydrates for breakfast, there's a snack time should not go beyond 20 grams, like that. That is basics. Then when I do carbohydrates counting, matching insulin to carbohydrates in grams, that is now advanced carbohydrates counting. That before I inject, and it's very common when using Lantus, Humalog 3 times a day, means I need to know how many grams of carbohydrates are in for my breakfast. If it's 50, my doctor said it is 1 to 15. That is the insulin carb ratio. So that is what we call advanced carbohydrates intake. Remember, these are tools. And for example, this will help you now, exchange list will help you now to know one slice of bread is 15 grams of. It can be interchanged with a cereal, it can be changed with maybe half cup beans. Now, this is the time again in carbohydrates counting, you need to know the sources of carbohydrates. Milk being the sources of carbohydrates, as you can see down there, it has 15. A fruit, beans now being our proteins. Now, again, it comes to being in the group of carbohydrates. Rice, mashed potatoes, the matoke, the arrowroots you saw, all those are under starch. So you can see down there the starchy vegetables. They are very little in terms of carbohydrates. So we should encourage. But again, you don't encourage a lot of vegetables. To an extent, the child is eating and is not adding weight. So in carbohydrates counting, it gives the child flexibility of eating and not that eating, overeating, running around the kilocalories required in a day and being flexible like the rest of the children. We can use carbs. That's what we have at the household measure. Carbs like 250 carb. When we say half a cup of beans has 15 grams, half cup of garlic has 15 grams. Or we can use hand portion size. Like a fist, that is 1 cup. Like a handful of nuts, a teaspoon. So we have measurements that we can guide them. These teaching aids should be in your office as nutritionists, just to help them understand immediately. If I say 1 cup of beans, what does that mean? Or if I say 1 cup of rice for breakfast or for lunch, what size of that cup? And in our standard, if we check in our clinical dietetics manual, we use the 250 ml cup, and it's basically available in most of the household houses. So again, they want to eat something in the supermarkets. Our children are very ahead. Remember, these are type 1s, very ahead. They'll just tell you, I'm eating it. When you are feeling it will make the sugars go up, already they're telling you, it has only 20 grams of carbohydrates from the servings. So you are left there. So they need to be taught. If they can have something from the supermarket, they can go like a yogurt, pile. I normally see them. All these kinds of yogurts, they've already written some serving size and some amount of carbohydrates that they have. In European countries, but this is, we can say in European countries, but in Nairobi, we get this kind of patients. They're also measuring their food. They have a weighing scale. When they weigh food, the main key here is the scale. And they already understand about calculating the carb factor. These are foods which have been grouped, and when you weigh, you times. If I weigh an apple, I know an apple weighing 150, you times maybe 0.11 as a carb factor. So most of the households in European countries, they weigh their food. But as here, as we start, we need to use our household measurements as much as possible so that our children understand. Remember, we have come from far. And now the good thing from the past presentation, most of our children, type 1 diabetes, are moving. Most of them have moved to multiple daily injection, which is a very good thing. And we encourage that all of them to move so that they'll have good glycemic control and they'll have good future. So like the way I was saying, I think this slide I've already spoken about it. A boy who's at 50 percentile should weigh approximately around that 5 kilos. Then you calculate. This is why now the nutritionist come in. A diabetes nurse will just use a plate method. If the nutrition is not in, just say, this is what you'll do, then the next time you will see the nutritionist, so that the nutritionist will help now to come up with the calories required for growth, for development of this child, other than using the plate method. Plate method is an idea for just ensuring that this child is eating healthy, is having vegetables, there's some milk somewhere, there's a fruit somewhere, but now here it is specific, a diet plan, which is needed. A diet plan of 2,100, a diet plan of 1,500, a diet plan of 1,800 individually, written patient X. This is the amount you're supposed to consume by the end of the day so that to have good glycemic control. Number 3, there's a question. Next one, please. Can you post? The question says, which one of the following is not a principle to consider when doing a meal or a diet plan? Remember, we had some principles. There were around 6. So, which one is not? All the above: variety, moderation, balanced food and nutrients, adequacy in one food nutrients. Which one is not? Yes? We are done. Wow. You see, it is very good to read in between the lines, the statement. It's good to finish. Adequacy in one food nutrients. We said adequacy in all food nutrients. That is one of the principles. So A, with 3%, is not a principle to consider when doing a meal plan. It should not be adequate in only one nutrient. It will be adequate in all nutrients that we have mentioned. It should be balanced, yes. In moderation, yes. Varieties in diet, yes. And all of the above, no. So thank you so much. Reading in between the lines is very important. So as we have talked all this, we have mentioned from the beginning, we have to agree where we are in our economy, Kenya. We don't know how many people are affording 3 meals a day and the snacks that we are crying about for diabetics, okay? And even for growing children. When do we say food security is an important social determinant of health? So, when we talk about food security, it's all about people having food at all time, and also the economic, in terms of economic access, and safe and nutritious to meet their dietary needs and preferences. Where we are with our economic, I don't think there are food preferences now. We are eating what is available, if you agree with me. So that is why full assessment is very crucial to ensure that these children are able to access what they have when they're in this daily multiple injection. So food insecurity is the opposite of the above. It is really a challenging. So it is tailored nutrition counseling. Now you tailor it after the assessment and how the family is going to have food at the household level. So I love iPad. They have taught me a lot. So I love using them for my references and our Kenya National Clinical Nutrition Dietetics Reference Manual. So I think there's a video we have to check to wind it up of what we have said all through before we wind up and go to questions. Sorry. Oh, sorry. It's just 2 minutes. Thanks so much. Now back to the audience. I can see there are some questions which needs to be answered. Catherine?
Thank you so much, Esther, for the very insightful presentation. We appreciate. Now to the questions. The first question was from an anonymous attendee. He asks, aren't fruits simple sugars and thus greatly affect blood sugars?
Okay. The sugars that we get from fruits is natural fruits. So it should be incorporated in our diet. What matters is how many fruits are you going to eat? Remember, when we talk about carbohydrates, they affect blood sugars. And when we talk about carbohydrates, we have starch, we have fruits in carbohydrates group, we have milk. This is what will affect when we now go into the point of carbohydrates, how they affect the blood sugars. So fruits are among. So the most important thing with a meal plan, you'll be able to know when to have your fruits in between. But the sugar from fruits is a natural sugar.
Yes. Thank you, Esther. The next question was again from an anonymous attendee. They ask, is stevia okay to use as a sweetener for a child with diabetes? Is it okay to use stevia, which I think is a sweetener?
Yes, like in our country, we have those sweeteners in the supermarket, in the shelf of pharmacies. What we have seen, the Food, Drugs and Administration, they have recommended use of stevia but in small quantity, according if I think I was to give a website where they are recommending on how to use it. So it is okay to use it, but also it's good to teach children as they grow, to withdraw, because we don't want them to use as all through. They can just use natural sugars from natural food. So the Food, Drug and Interaction and Administration, have recommended stevia as one of the sweeteners, which can be used in adding to tea, to porridge, to ensure that you have parapirate of that food. Yes?
Thank you, Esther. This is a question from Sylvester Wangumba. What is the management of an under 5 child with type 1 diabetes with severe malnutrition? Again, he asks, maybe you could answer both questions. Is it okay to administer parenteral nutrition to these patients when there is need? The same patients with malnutrition who are under 5, but with diabetes.
Thank you for that question. The thing here, malnutrition is very common in developing countries, and by part chance, you might get that also this child who is malnourished has diabetes. So the question here is, how do we manage this child who is malnourished? Remember, it's teamwork. Me as a nutritionist alone, I'll not be able to team with the caregivers. So the doctor, the nurses, education, we will have to come together, because what we want to achieve is the growth and development of this under 5. So the first thing is to do nutrition assessment. And when you do nutrition assessment, you are going to get how this child is eating, what this child is lacking. Either this child is not eating completely, is admitted in the hospital. So what can you do as a nutritionist? The child in the hospital, type 1 diabetes, admitted, and what can you do? There are so many options of feeding this child. Number 1, encourage the small that is able to eat. Then number 2, if not able to eat, remember there are other methods of feeding. You go enteral, or you can do TPN. TPN, by the way, can be done to type 1 diabetes if they are not feeding completely, depending on the diagnosis of this child. They can be put on TPN. What the doctor needs to come in is to increase the dose of insulin so that to cater for this TPN now coming in. So still we can help them with malnutrition and diabetes, depending on which mode of feeding we are going to use. Yes.
Thank you, Esther. Another question. How does the ratio, I think this is the carb counting, the insulin to carbohydrate ratio come about? Who decides 1:30 or 1:15, or what is the criteria?
So if you decide in agreement as a teamwork, with the doctor agreeing that all type 1s, we are going to teach them about carb counting. So you see now, the role of the doctor is to come up with the amount of insulin this child is going to use. Let's say both short-acting and long-acting. Basically, carbohydrates counting is very good when the child is using these daily injections, the way I said, the multiple daily injections. But for the premix, the child is using maybe 1 in the morning, 1 in the evening. Now carbohydrates counting cannot come in. I said this is when you do basics. You say, I want you to be having this 1,500 kilocalories, then I want you to have this amount. So you stop there. But carbohydrates counting, you now come, no, this is 50 grams for my breakfast. Then I'm using Lantus this amount. I'm using short-acting this amount. So you decide with the doctor. But the insulin carb ratio is very common. Like we say, as a start, the doctor can say we do an insulin carb ratio of 1 to 10 or 1 to 15. And this is where we come up with insulin correction factor. We are going to correct. And in this insulin carb ratio, it needs a lot of checking of the sugars, the fasting, the postprandials, the pre-meal sugars, and also the sugars after 2 hours to see how a certain amount of carbohydrates that you are having. I'm not saying when you are doing insulin carb ratio, you overeat. You are still fixed on your calories, but the idea here, you are aware, like lunchtime, I'm going to have 60 grams of carbohydrates, and I'm going to have an insulin carb ratio of 1 to 15, meaning I'll have 6 units of Humalog. Then I'll check my sugars, that is the insulin carb ratio, to see if I'm within the target. I don't need correction. So it's a topic of its own. It is decided by a multidisciplinary team. I cannot decide alone. I'll be running on my own island. So we decide as a teamwork, as the doctor, the nurses, this is the way to go. And most families will come with their children. We just want to do carbohydrates counting. Yes. That's why we call it advanced, where the insulin carb ratios are used, correction factor comes in, and it's about flexibility, a child understanding. Milk has sugar, natural sugar. Fruits, they have natural sugar. Now beans also, they have glucose, like that. Yes. But the way it's a topic of the whole 1 hour, teaching about carbohydrates counting. Thank you.
Thank you, Esther, for that. From Jay Muta and Itan Kirote, I'm going to combine both of their questions because they're talking about the same thing. About keto diet, Jay Muta asks, keto is zero carbs, or rather it's low carbohydrate target, an option. And then Itan Kirote is asking, is it advisable to follow the plant-based diet, which is the keto diet? And why is the intake of fat limited, yet it doesn't raise blood sugars?
So the issue of keto diet, I'll not talk about it for now, because right now we want these children to grow, okay? There's so many research about keto diet. Keto diet will be the best when the child has neurological issues, not with diabetes, because it reduces there's some research which has been done about keto diets and children with neurological issues. So for now, type 1 diabetes and the keto diets, I do not recommend. And remember, we said about balancing our meals. We don't eat a lot of fats. We don't eat a lot of protein. We don't eat a lot of carbohydrates. The requirement is more of carbohydrates followed by fats than protein. That is the scientific requirement. Yeah, we have some people who are vegan, like where I work. Most of my clients come from families where they are doing plant-based diets. So it's about asking them, about teaching them on how to balance and also how to meet the other nutrients which are recommended. For example, those ones which are like B12, how we can supplement so that these children can grow. Yeah, we have families who are vegan, who are plant-based diets. nothing else. So it's through the assessment and how you are going to help them as a nutritionist. Yes?
Thank you, Esther. Two more questions or so. What is the recommended RDA for children and adolescents with malnutrition? Okay.
Recommended what?
RDA.
Is it protein, fats? You know, with malnutrition, this is a child who is sick. So the recommended RDA of carbohydrates, protein might tend to go up a little bit so that to meet the catch-up growth of these children. Yes?
John, Esther, one more question, Esther. This is from Fauzia, and Fauzia says, hello, what about dried fruits like dates, which are extremely sweet? Is it safe for people with diabetes? Thank you.
Yes, like fruits, you know, depending which fruits you have on the table. Remember, when like dates, I have communities who love dates, and more especially when they're doing fasting, they open up with dates. The issue here, it's about how many dates are you eating, even if they're dry or fresh. Quantity is what matters. And if the quantity is high, it is going to affect the blood sugars. If you go on small portions, the way we said, being disciplined, even if it's sweet, it will not affect the blood sugars. Yes?
Thank you, Esther. Somebody asks, for those children who are born with diabetes and they are under 6, and remember we do exclusive breastfeeding. Yes. Will we still do breast milk or we have something else?
So the World Health Organization recommends exclusive breastfeeding up to 6 months. Exclusive breastfeeding. So still, we'll keep on doing exclusive breastfeeding and managing this child, sugars not to go up. Like I can say the youngest I've managed was 7 years old when they had started complementary feeding. So 7 months. So still, this, because of what was happening, the environment around, the child stopped feeding. So where we are, the only source we had is breast milk. So the mom kept on breastfeeding. We kept on bringing the sugars down. You can even, I saw even the doctor giving half units after breastfeeding. You see? So still we manage them. We'll still have, enable them to have their rights of exclusive breastfeeding with teamwork from the doctor, the nurses. I think they can be managed very well. So we don't stop breastfeeding. Yes?
Okay. The last question, Esther, just before we close. Can a diabetic patient depend on diet plan without drugs to control blood sugar?
So this is type 1. Today we were talking about type 1. Type 1 is an autoimmune disease. Destruction of the insulin-making cells. So diet alone cannot work. This is a child, the best treatment immediately is to be on insulin. So diet comes in to help, okay, in terms of managing the sugars. So we cannot manage a type 1 with diet. But for type 2, depending on how you do it, how strict you are, and how self-disciplined you are, we have seen people managing diabetes with diet alone, exercise, diet, coming in, but not type 1.
Okay, thank you, Esther.
Yes.
Allow me to close the webinar for today. Thank you for the insightful presentation that you've had for us today. And thank you to our esteemed audience for your participation during this session. I hope, and we hope as a team, that you are more knowledgeable on nutrition and diabetes type 1. We have taken note of the queries that we were not able to answer in the webinar today, and we will be circling back to respond here and share during the subsequent webinars, which we'll be having every week. Okay. I will now turn it to Esther for your last parting shot before we close it, before we call it a day.
I can say thank you for joining. Nutrition and type 1, what I can say, nutritionists have a great role to ensure these children grow. So we are very important in the part of the teamwork, and let us, as nutritionists who are here, don't be encouraged, don't be discouraged. Still, there's a lot we can do. We need a lot of reading. We need these children to grow because they are the future leaders, the future doctors, diabetologists. So we have a great role to play. And diabetes and nutrition being the most important section that we need to deal with. Thank you so much for the participants. And I think if I was not able to answer the questions which were asked, maybe we'll answer them online. Catherine, is it possible?
Yes, we will be answering them as we continue the subsequent webinars.
Okay.
And online also.
Thank you so much,
Catherine. Please be on the lookout for more webinars on the Cambridge Research website. Thank you. Have a good evening, good morning, good night, wherever you are. Thank you.